Hello, and welcome to this short video on antibiotic usage and sepsis management in prolonged casualty care. I'm Dr. Woodard, and I'm going to take you through an overview of sepsis. This video is intended to accompany the lecture given during the prolonged casualty care course. Let's start by defining sepsis. Sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. The infection can be bacterial, fungal, parasitic, or viral. All of these sources of infection have the potential to worsen to the point of organ dysfunction if the host defense is overwhelmed and the infection is left untreated. Malaria is one type of parasitic infection that you may encounter and can lead to sepsis. For our patient population who are generally healthy and have intact immune systems, sepsis due to fungal infection is uncommon. However, this can become a concern with dirty, deep wounds secondary to combat polytrauma, fungal spores from explosions, or in burn victims. Candidal fungal infections may follow penetrating abdominal trauma with perforation of the gut, and invasive molds may arise after blast injuries in devitalized tissue, for example, in an amputation or a crush injury. This PCC course focuses on bacterial infections, since they are the most common cause of sepsis. Let's look at how it starts. Remember that infections exist on a spectrum which ranges from a local infection to septic shock. At one end of the spectrum, a cut is seeded with bacteria from the environment. Normally, our immune systems will fight off the infection and the wound heals. However, if the immune system is overwhelmed by the type or quantity of bacteria, then the infection will spread from a local wound to a systemic infection with bacteria traveling throughout the body via the blood. In this case, treatment with antibiotics is critical. At this point, the infected host has sepsis and will show signs of organ dysfunction, which can manifest in many ways and include altered mental status, impaired oxygenation, reduced urine volume, or hypotension. Left unchecked, this will progress to the worst case scenario, septic shock, which is life-threatening hypotension requiring vasopressors to maintain a mean arterial blood pressure of at least 65 millimeters of mercury. The key difference between sepsis and septic shock is that septic shock is characterized by life-threatening hypotension. Patients are dependent on the use of vasopressors to support a blood pressure high enough to ensure organ perfusion and sustainment of life. Septic shock is also called distributive shock because an inflammatory response to infection causes blood vessels to relax and lose tension. Compared to the normotensive blood vessel on the left, the blood vessel on the right has vasodilated or stretched and become leaky. Red blood cells are large enough to stay inside the blood vessels, but liquid leaks out or redistributes. Pressure drops inside the blood vessels, leading to hypotension. It's important to remember what is happening when someone goes into septic shock because this will help you recognize it and understand how to treat it. The progression along the spectrum from injury to sepsis to septic shock may take hours to several days. This progression is important to keep in mind because it can help differentiate between two different types of shock, hypovolemic and septic shock. In hypovolemic shock, blood loss due to trauma causes low blood volume. The blood vessels still function properly like the blood vessel illustrated on the left. The remaining blood volume is restricted to the body's core by functioning blood vessels. This shuts down blood flow going to the limbs, causing them to feel cool to the touch, and is one of the characteristic findings on physical exam. Blood pressure can be maintained once the patient has the volume resuscitated, ideally with fresh whole blood. In distributive or septic shock, an abnormal response to infection causes the blood vessels to become relaxed and leaky, allowing fluid to leak out through the sides like the blood vessel shown on the right. Since blood is not restricted to the extremities, they feel warm to the touch. Treatment is focused on treating the infection, replacing lost fluid, and maintaining blood pressure. When diagnosing shock, consider that you may have one or both types of shock occurring simultaneously. If in doubt, remember, All trauma patients arriving from the field are assumed to be in hypovolemic shock unless otherwise determined. Use the March algorithm to assess and reassess the patient. Consider time of injury, patient presentation, vitals, as well as effect of previous treatments and interventions rendered. Treatment of sepsis centers around antibiotics and fluids. The goal is to give antibiotics within 1 hour of sepsis recognition. When treating sepsis in the prolonged casualty care environment, the goal is to get the patient to a higher level of care as soon as possible. Joint Trauma System clinical practice guidelines identify antibiotics with minimum, better, or best categories. The minimum category should be sufficient for most superficial infections you encounter. The antibiotics in the better and best categories target a wide range of bacteria. This broad coverage ensures that almost all bacteria will be susceptible to the treatment. Start with oral moxifloxacin once daily at a minimum for prevention or treatment of infection. You can start with antibiotics in the better category if the injuries are more extensive, or you can escalate therapy if the patient hasn't improved on moxifloxacin alone. Use antibiotics in the best category if the patient has penetrating abdominal wounds or if they haven't improved on antibiotics in the other treatment categories. In addition to antibiotics, treatment of sepsis involves administering fluids. This can be in the form of an oral rehydration solution if the patient is able to drink fluids, or IV crystalloids to maintain systolic blood pressure greater than 90 millimeters of mercury, with lactated Ringer solution as the preferred intravenous fluid. In septic shock, the treatment additionally involves giving vasopressors in order to maintain a mean arterial pressure of 65 or systolic blood pressure of 90. In the PCC course, you will only have access to a manual blood pressure cuff, so your goal will be to maintain a systolic blood pressure of 90. During the course, you will learn how to set up an infusion of either norepinephrine or epinephrine as part of this treatment. Antibiotics are an important part of treatment, but you must also achieve source control to eliminate the source of infection. The most common cause of infection leading to sepsis in our patient population is skin or soft tissue infection. However, consider additional sources of infection, which can include meningitis, urinary tract infections, or an abdominal infection like appendicitis or infectious diarrhea. Furthermore, anytime an intervention is performed where a foreign body enters the patient, there is a potential to allow bacteria to enter as well. Catheters from IVs or a Foley can become a source of infection. Sometimes the source remains unknown, but it is important to try and locate the source whenever possible. Once found, any wounds should be thoroughly cleaned and then monitored frequently and reevaluated. Here are some tips to help you address infection and administer antibiotics. Source control can be achieved by removing foreign objects or dead tissue. Inspect all wounds. Initial treatment should consist of cleaning the wound, using ample irrigation, and debriding dead tissue. Then regularly re-examine wounds to ensure adequate wound healing and treat as needed. The two antibiotics that are used in TCCC and are readily available are ertapenem and moxifloxacin. When choosing between these antibiotics, consider the antibiotic coverage and route of administration. You cannot give moxifloxacin, which is an oral medication, to an unconscious patient, but it can quickly be administered to someone that is alert and can swallow. As you progress in your learning, be aware of additional antibiotics that may be preferred in certain situations. For example, levofloxacin is an oral antibiotic that provides better coverage in wet terrain or jungle environments. Then, in the case of penetrating abdominal wounds or septic patients that haven't improved with other antibiotics, combinations of ceftriaxone, vancomycin, and moxifloxacin can be used. Lastly, remember to de-escalate antibiotics when appropriate. When transitioning from an IV antibiotic like ertapenem to an oral antibiotic like moxifloxacin, begin oral moxifloxacin immediately after the final dose of ertapenem for antibiotic overlap. Here are a few tips for administering fluids. First, be aware of over-resuscitation. The initial fluid bolus should not exceed 2 to 3 liters. Urine output greater than 0.5 milliliters per kilogram per hour indicates over-resuscitation. Different ways to track response to fluid resuscitation include urine output, blood pressure, and mental status. You can also use capillary refill time to guide resuscitation as an adjunct to the other measures of perfusion. Track and record hourly urine output with a target of at least 30 milliliters per hour. Placing a Foley catheter will give you the most precise measurement, but is not always necessary in an awake patient. Be creative with your containers for measurement. Balanced crystalloids, or lactated Ringer solution, is preferred over normal saline in sepsis, but lots of fluids might be needed for treatment, so manage your resources and use what you have. Here are a few tips for using vasopressors. In sepsis, vasoactive drips will only temporarily correct hypovolemia, and then the patient will become unstable again until the fluid volume status of the patient is corrected. Check IV sites regularly. Peripheral vasopressors can damage tissue if it extravasates. Don't overshoot your mark. Initially target mean arterial pressures of 65 and systolic pressure of 90. Higher blood pressure does not mean better outcomes. Monitor vitals every 5 minutes or as frequently as possible while adjusting pressor dose 1 to 2 micrograms per minute at a time. When down titrating or reducing the vasopressor dose, adjust the dose slowly, not more than 1 to 2 micrograms every 20 minutes to allow time to assess the response. Here are some additional tips for using vasopressors. Become familiar with the drip table for epinephrine and norepinephrine. The 2 columns on the left tell you what to mix in order to achieve the desired concentration. For example, epinephrine vials come in a 10 ml vial at a concentration of 100 micrograms per ml. If you have a 100 ml bag of normal saline, you will need to add 2 milliliters of epinephrine to this bag to achieve the desired concentration. If you have a 250 milliliter bag, you will need to add 5 milliliters, and for a 500 milliliter bag, you will need to add the entire vial or 10 milliliters. All of these methods will give you a final concentration of 2 micrograms per milliliter. Once you've mixed your solution, it's very important that you don't forget to label the bag with the name of the drug, the concentration, date, and time. To administer the medication at the goal rate of 4 micrograms per minute, you will need to adjust the drip rate. This will be covered in lecture and in a skill station, but I will introduce this briefly. Every set of IV tubing has a set drip rate which tells you how large a single drop is. Most of our tubing is 15 GGT, or 15 milliliters per drop. So we will use the drip rate of 30 drops per minute shown in the last column. 30 drops per minute is the same as 1 drop every 2 seconds. When you set up your epinephrine solution using the columns to the left and set the drip rate at 30 drops per minute or 1 drop every 2 seconds, the dose of epinephrine that you are delivering is 4 micrograms per minute. Then you can adjust the drip rate in order to change the dose. For example, slowing the drip rate down to 1 drop every 4 seconds will deliver a dose of 2 micrograms per minute, or dropping the dose in half. Alternatively, speeding up the drip rate to 1 drop every second doubles the dose to deliver 8 micrograms per minute. And further increasing the drip rate to 5 drops per second increases the dose to 40 micrograms per minute. That wraps up this brief overview of sepsis. I hope you found it helpful, and I look forward to seeing you in the course.